This meeting is being recorded.
So I've just got a video here to show you how to actually hand irrigate a bladder to make sure that you wash out any of the clots that are in there. So you always use sterile water, use a big bladder syringe, and you inject 2 full syringes to fill the bladder up. And after you do that, you irrigate. So I'll just show you there. So you can see them pulling out the clots there. So fill the bladder and then pull back out and do it all over again. And so you do it as many times as you need to make sure that your urine starts looking clear. So you want it to look like that. Great. So you keep going. After you've done the bladder washout, you put them on an irrigation solution. So basically, you run that solution through this 3-way port, and then you get urine coming out of the catheter bag, and you can assess the hematuria. Usually you leave the irrigation on overnight, and then you reassess them in the morning to make sure that it has resolved, and then you can stop the irrigation fluid. So we'll talk a bit about catheter problems. So if you have a blocked catheter and you called onto the ward to assess somebody with a blocked catheter, the things that you normally do is flush the catheter, make sure the catheter is sitting in the right position. So remove the port where the catheter is actually draining from and use a bladder syringe that's 50 mils and push saline in and see if you can get any output from the catheter. If you can't, then deflate the balloon and try and move the catheter around, and then try and see where you get fluid or where you get urine, sorry. And when you do, then you can make sure that you're in the bladder and you can refill the balloon. If you have excessive bleeding after a catheter insertion, it may be likely that your catheter is not in the right place. It could be that the balloon is inflated in the prostatic urethra, in which case you need to take it out immediately and reinsert another one properly. If you're unable to take a catheter out, and this has actually happened before, a good tip to use is that you can cut the catheter at the port. So where you see the port, let me go back to a picture that's useful. So here, you can actually cut this balloon port, and that will deflate the balloon on its own, and then you'll be able to remove the catheter. That's a good tip that I learned on the urology ward. Okay, and last but not least, we're going to go through a renal colic. So you have somebody presenting with loin to groin pain, with severe severity of the pain, nausea, vomiting, with some renal angle tenderness, and the urine dip with hematuria. Now, the things you want to do, the investigations you want to do, obviously send off some bloods for them, but also you want some urate and calcium levels. You want to know the stone composition, and possibly it could be because of the urate and calcium levels. And very importantly, a non-contrast CTKB, so that you can actually see the size and location of the stone. So stones can collect in so many different places, but the most common places are you can have a stone in the calyces, in the pelvis, in the pelvi-ureteric junction, in the ureteric, mid-ureteric junction, and in the VUJ. So these are all the common places that you can have stones. And depending on where they are, the treatment is very different. So for you, the important things to know are, why would we admit somebody with a ureteric stone? So one, patient's pain. So if they cannot tolerate their pain and cannot be managed with PR diclofenac, which is the best thing to give for patients with stone symptoms, if they can't handle that, even with the PR diclofenac, then they need to be admitted for regular analgesia. Second thing you need to think about is, do they have an infection? So if they have a stone, as you can see here, this person has a stone with the hydronephrosis. Is there any infection? So are their inflammatory markers raised? Is their urine dipstick positive for nitrites and leukocytes? Do they have a fever? Are they tachycardic? Are they presenting like they have sepsis? If they have an infection and they have an obstruction, as you can see here, this is an obstructed kidney, then this patient needs urgent management, so urgent surgical management. And last but not least, is there an AKI? So you look through their U's and E's, you look at their baseline. If they have a derangement in their renal function, then that's another reason that you want to admit this patient. After you admit this patient, you treat them with IV antibiotics for the infection, and you want to de-obstruct them as soon as possible. And how do you de-obstruct someone? You put in a stent for them. So here is an abdominal x-ray, and this is just so I can show you how a stent actually looks. So you can see this is in the kidney and this is in the bladder. So it's a plastic tube that sits between the two, allowing the drainage of urine from the kidney to the bladder. And the stent is there to help with symptoms of de-obstruction. It also does tend to help with pain. And the reason that the stent is coiled in the kidney and coiled in the bladder is so it doesn't become loose and fall out. And how we put a stent in is we use a camera. So this is a cystoscope. And we insert that just the same way that we put a catheter in. We get into the bladder and then we insert the stent up the ureters into the kidney. Great. So the long-term plan. So this patient's come in with a stone. So you can say a mid-ureteric stone that's here. They're hydronephrotic. You've put in a stent for them. Great. But you haven't actually managed the stone that they have. So how do you manage the stone? So that would be a long-term plan. So if it's a small stone, so less than 5 millimeters, and it's quite low down in the urinary system, it can pass on its own. So you can give them some analgesia. The stenting may help with the pain. It may help with their renal function, and then you can get them home and just monitor them as an outpatient. Now, if that is not the case, if the stone is slightly bigger, then you have a few other options. And I'm not going to go into much detail, but just so you're aware of them. So lithotripsy. So you can administer shock waves to break up the stones, but this can only be done if the stone can actually be seen on an abdominal x-ray. So before you send somebody for lithotripsy, just make sure to do an abdominal x-ray to see if you can see the stone. Then ureteroscopy. So this works the exact same way as this cystoscopy, except that you go up the ureters with a different instrument that is slightly thinner than this one. So you go up with a camera, look all the way up into ureters, and you find the stone. Find the stone, and then you can blast the stone with laser. And the third option is percutaneous nephrolithotomy. So this is also short form called PCNL. Is also an invasive procedure, but you go directly into the kidneys and then you blast the stone. So these are all the different options to manage a stone, and depending on the size, the location, the patient demographics, we might pick a different management. If this patient has presented for the third or fourth time, forming a stone, becoming infected and obstructed, requiring stents for a long period of time, then we need to send off calcium and urate levels and send the stones off for analysis, and also think about why are they forming stones. And there is usually an option to refer these patients to a metabolic stone clinic to try and help them figure out what lifestyle changes you can make, and what other investigations you can do for them to try and help them. So that is all the common conditions that I thought to cover. This is just a link for any feedback that you wanted to give me. And this is some references that I've used. Thank you so much for your time today.
Thank you, Kamashi. That's everything for today. Have you